Hey everybody, I'm Peter. I'm a fourth year med student. Welcome back to Patho-Mnemonic. Um, you guys are probably familiar with how this runs, but for those of you who are new, this is an NBME Shelf exam and Step 2 content review series. Um, each episode, I'm aiming to cover content within the scope of like a single shelf exam, and then obviously all of the shelf exams fall under the window of Step 2. Um, in this episode, I'm going to go over some high yield psychiatry stuff. Um, so, yeah, without further ado, we'll go ahead and get started. Our first vignette is a 20-year-old female. She's brought to the ED by police after she was found wandering in the middle of the street. She claimed that she needed to escape from her roommate who was planning to kill her in her sleep. She appears disheveled. She describes her mood as anxious and fidgets uncomfortably in the exam room. She begs the physician not to call her roommate. Her parents note that her grades have dropped significantly during the past academic year. And then which of the following is the most likely diagnosis? Um, there's a pretty extensive differential in the multiple choice question. You will probably see questions like this, unfortunately, and so you just kind of have to know what's going on. Um, but for those of you who are just listening, the choices are generalized anxiety disorder, panic attack, delusional disorder, brief psychotic disorder, schizophreniform, schizophrenia, schizoaffective disorder, schizotypal personality disorder, schizoid personality disorder, or major depressive disorder with psychotic features. Okay, the correct answer to this one is actually schizophrenia. Um, we will go over all of the other like psychotic conditions coming up soon, but um, just a quick comment on some of the vignettes that you'll come across, especially on psych vignettes and like on the shelf or on step two. A lot of the times you'll, at least from my experience, I would get frustrated because sometimes I would feel like there's a really critical piece of information that's not included in the vignette that would have made the diagnosis like so much easier to make. Um, and if you find yourself in, backed into that corner, the more important thing is to just focus on what they do tell you. So I intentionally, like, you might have thought, well, she said she's anxious and her grades have dropped and she has this worry that her roommate is going to kill her in her sleep. So you might be led down the wrong path. It's like, oh, this could be generalized anxiety disorder, or this could be a panic attack. Um, a quick comment on generalized anxiety disorder. Those features are usually like persistent worry about most things most of the time for at least 6 months. Um, so there's really nothing in this vignette to suggest that she's worried about like everything. She just has this one specific concern that her roommate is going to kill her in her sleep. Um, she's not worried. So it's like she's not worried about most things. And it doesn't like explicitly suggest that she's worried about them for most of the time. And then a quick like mnemonic that I use to remember the diagnostic features of generalized anxiety disorder is Pam. Like Pam is worried about most things for most of the time. Like, oh yeah, my name is Pam. I'm worried about very silly, but it's how I remember it. Um, it's not a panic attack because she doesn't say that she has this feeling of like loss of control or impending doom. Um, those are usually some classic features that are like mentioned in the vignette for someone that has a panic attack. They don't, in the vignette, they don't like assess her vitals. Patients that come in with panic attacks, like they might have sinus tachycardia or they might be tachypnic, but there's no vitals in this vignette, so don't even think about that. And then there's no somatic symptoms. Sometimes people with panic attacks will come in with like chest pain or shortness of breath, um, or like dizziness or nausea, but there's no somatic symptoms in this vignette. And then the rest of these conditions on the differential, we will go through in more detail. But the correct answer to this is schizophrenia. I also kind of wanted to make it a little bit difficult, just so it wasn't just like a slam dunk diagnosis of schizophrenia, because in reality, as you're taking your psych shell for your step two, you're probably not going to have every single question be a slam dunk diagnosis. But it makes for good discussion. Anyway, so the diagnostic features or criteria of schizophrenia is at least two of the following five features, and then you need at least one of the first three. So the five features are delusions, hallucinations, odd speech, odd behavior, and then negative symptoms. So the first four features are all considered like positive symptoms, and you differentiate positive and negative symptoms. But the way that I remember the difference is positive symptoms is something abnormal is present. So like, a delusion, a hallucination, disorganized speech or disorganized behavior, those are all new things that like aren't normal. Negative symptoms like diminished emotional expression or avolition or just like not interested in doing anything. Those are examples of negative symptoms. So it's the absence of something that's normal. So someone who has diminished emotional expression, they might have one of the ways that it'll be described on a vignette is they have a flat affect. So they could be describing something super exciting or super depressing, but their face is like stone cold normal. Um, where normally, like a person who's describing that kind of stuff, they'd be smiling and super excited about describing like something really good that happened recently. So that would be a normal emotional expression, but then a negative symptom would be the absence of that or the flat affect. Um, so in the vignette that we were just talking about, the 20-year-old female, she had a very prominent delusion, and then she also had uh, odd behavior. So she was like, or not odd behavior. She had negative symptoms. She had like avolition, and it like if we return to the vignette here, the delusion is pretty clear, right? She has this roommate who's planning to kill her in her sleep. But it's kind of hard to pick out. It doesn't say explicitly that she had avolition, but you can piece that detail together because she's disheveled, which means that she's not taking care of herself. And then when you call her parents, they say that her grades have dropped, which means that she's not like studying for school or like taking care of that other stuff. So those are um, like you kind of have to like piece together the narrative in the vignette to make this diagnosis. Um, so she had the delusion and the negative symptom, which is two, and then it was for the past academic year, gives us the timeline of a year approximately. And then in order to make a diagnosis of schizophrenia, it needs to be for at least 6 months. And the way that I remember that is schizophrenia for schizophrenia. You might also see options between like brief psychotic disorder or schizophreniform or schizophrenia. Um, the timeline from shortest duration to longest duration, if you see like psychosis consistent with possible schizophrenia lasting anywhere from a day to a month, that's brief psychotic disorder. If it's anywhere between 1 month and 6 months, that's schizophreniform. And the way that I remember that is it's like schizophrenia is starting to take form in schizophreniform. And then if it's longer than 6 months, it's schizophrenia, like we saw in this vignette. Um, okay, before I go on to the next vignette, another quick comment on like just psych questions in general and the psych shelf and step two questions. It's like very like diagnostic criteria heavy. And there's also a lot of questions on like pharmacology. Those are probably the two most important things to remember for your psych shelf and psych questions on step two. So that's really kind of what I wanted to gear this towards. And as we were seeing, like it's very easy to like, look at a slam dunk diagnosis of schizophrenia or depression or bipolar or something like that and be like, oh yeah, this is definitely a diagnosis. But like the NBME really likes to give vague vignettes that could really make the case for like one condition versus another. So you really have to like stick to your guns and know the diagnostic criteria to be confident in making a diagnosis of something. Okay, so here's where we'll get into all the different disorders that fall under the schizo umbrella. Um, so we'll start with schizotypal personality disorder. Uh, these consist of things like magical thinking, odd or magical beliefs. Someone might be described as like very eccentric and they have a eclectic collection of antiques or weird things in their house. They wear mismatched socks. They're just kind of like odd. Um, okay, contrast that with schizoid personality disorder. Um, this is someone who's a loner. they self-isolate, and they don't really care for social interaction, but they like it that way. So the way that I remember it is it's like when someone has schizoid, they behave like a droid because they're like all by themselves. They're just like a unit. They just do their own thing and they don't really care about social interaction and they don't mind it. These are the two kind of personality disorders that, like, when I was first learning about them, they were very confusing because, like, they're very similar in schizotypal versus schizoid, and you just have to remember the difference between them. But the like a droid is how I have separated schizoid from schizotypal. So hopefully that helps you. Um, You don't want to confuse schizoid or any other personality disorder with avoidant personality disorder. This is someone who is also a loner and they are also self-isolated, but they're afraid of social interaction or judgment and they're preoccupied with criticism. So they'll say like, "Oh, I don't want to go out to parties or like big social gatherings because everyone hates me or everyone thinks that I'm like a burden." Um, you might also see questions that contrast this with social anxiety disorder or social phobia. That's where they have like physical symptoms when they're in public places. Like they're afraid of judgment, they're afraid of criticism, but they like get nervous and they like get, palpitations or sweaty or clammy or things like that. Whereas this is just like a personality trait. Like they just don't go out to social interactions or like hang out with their friends because they're like, oh, I don't really like going out because my friends hate me. As opposed to like being afraid of going out. Um, you also don't want to confuse these personality disorders with paranoid personality disorder. This is someone who is, again, a loner and they're self-isolated. So you can see why there's a lot of confusion across these three personality disorders. But someone with personal or with paranoid personality disorder, they're paranoid or distrustful of everyone and everything. Not to the point where they're like a diagnosis of schizophrenia, right? Like they might be super paranoid and stuff, but like that's one. If you read the vignette and it's just like they're paranoid of everyone, that's not enough to suggest that they have schizophrenia or some other disorder. Like if they're just distrustful, then we can make this diagnosis. Um, on the topic of personality disorders, uh, this is often like the vignettes will be presented where someone comes to the outpatient office and they'll talk about like, oh, it's hard to make friends or they don't really have a lot of connections or blah blah blah. And then like on the interview, they have these features that we were talking about. You probably won't see this in the setting of someone who like comes into the emergency room with like an acute exacerbation, because these are like acute versus chronic continuum. These are more chronic conditions because of their weird personalities and their weird beliefs or their weird behaviors. That ultimately is what causes them to um, push other people away. And so that kind of gets in the way of them making friends and having significant social connections. Um, Okay, so we talked about personality disorders, then we'll talk about another schizo disorder, which is schizoaffective disorder. In someone that has schizoaffective disorder, they have psychotic symptoms that we were like kind of talking about with schizophrenia, but they also have mood disorder episodes like depression or mania, whereas you don't see those in schizophrenia. Um, contrast that, sorry, um, another distinguishing feature of schizoaffective disorder is they happen independently of the mood disorder episodes, um, which is important to keep in mind when you're thinking about mood disorder with psychotic features. So this is kind of like the opposite end of the opposite side of the coin, where you have psychotic symptoms, but they're only during mood disorder episodes. So someone who has schizoaffective disorder, it's kind of like their baseline to have these episodes of psychotic symptoms, like delusions or hallucinations, odd beliefs, or I mean, odd behaviors, odd speech, that kind of stuff. And then every now and then they'll have like a mood disorder, an episode, like a depressive or a manic episode. Someone who has a mood disorder with psychotic features, they're fine at their baseline. But then when they have something like a depressive or a manic episode, while they have that mood disorder episode, they also have psychotic features. So these are very, can be very tricky, but if you remember like what is happening when, then you can differentiate between the two. Okay. Um, on the topic of delusions, someone might also come in with like you'll see a vignette where like, I don't know, someone's wife brings them into the office because they're like behaving weird and they're like, you know, they'll describe their symptoms. Um, and then it's like, well, maybe they have schizophrenia or maybe they have delusional disorder. So the definition of delusional disorder is that they have at least one delusion for at least 1 month. Um, so the timeline is important to keep in mind, but it's also like just in isolation, they have delusions. They don't have any other features to suggest stuff like schizophrenia or schizophreniform, or like schizoaffective or MDD with psychotic features. It's literally just just delusions. So the definition of a delusion is a fixed belief that persists in the setting of contrary evidence. So this is like a bunch of big words and it's kind of abstract, but some examples might help put it into context. There are different types of delusions, one of them being jealous. So it's like, oh, my coworker makes so much more money than me, but then you like look at their payroll and you compare it to the payroll of their coworker and they're like making the same amount of money, or the patient is making more money than the coworker. So that's evidence contrary to the belief, but the belief still persists. You can have persecutory delusions where it's like the mafia is out to kill me. Or like we saw in the very first vignette, the 20-year-old female, she was like, oh, my roommate is going to kill me in my sleep. Um, so that's like like someone is following you and you're like being followed by like the government or someone that's close to you or something like that. You can also have erotomanic delusions where it's like, oh, someone famous is sending me love letters through like the television or through some social media or something like that, where it's like the patient believes that some figure is madly in love with them, but in reality, that that person is like not actually in love. Um, you can have grandiose delusions where it's like I'm the greatest person alive. I like am destined to be the supreme ruler of the world or something like that. These are usually pretty easy to pick out in a vignette. Um, you can also have somatic delusions where it's like I feel like bugs are crawling on my skin. Um, that's like a pretty high yield symptom of a somatic delusion. Um, You do not want to confuse a cultural belief, so like religious beliefs or idolatry or animism, as a delusion. So, like if someone from a different culture comes into the office or something like that, and they're describing something that seems like it would be a delusion, um, because it like disagrees with the culture, since we're in the United States, if they come in from outside the United States and they have a belief that is contrary to something that's culturally believed, like a cultural belief in the United States, it's important to keep in mind the context in which they were raised and the culture that they believe in at home, because the cultural evidence is like enough to justify their belief and not be a delusion. Um, what did I want to say? Oh yeah, and then the duration of a delusion, for delusional disorder is it has to be at least 1 month of duration. Okay. Um, As I was alluding to earlier, if there are other symptoms or features in this patient that has like a delusion, you want to consider alternative diagnoses. So, like I said, it has to exclusively, it has to just be delusions. You can have multiple delusions, but the moment you start seeing other things aside from delusions, you want to think about other diagnoses. Okay. Our next vignette is a 30-year-old male is also brought to the ED by police. After he was found wandering the streets, he claimed to have run out into the street to, quote, join the rapture and unite with God. On arrival to the ED, he appears disheveled and malodorous. He describes his mood as, quote, preposterously and presumptuously purple. He angrily yells at the physician that he is, quote, denying his ascension. And then which of the following is the next best step in management of this patient? So A is lorazepam, B phenobarbital, C intramuscular haloperidol, D oral haloperidol, E intramuscular aripiprazole, or F oral aripiprazole. Uh, think about that for a second. All right, the correct answer to this is F, oral aripiprazole. So this question is getting at the management of acute psychosis. This can kind of get a little nuanced, but I'll break it down here. In general, if someone comes in with acute psychosis, the first line you want to consider an oral second generation antipsychotic. And if you there are a ton of medications in general, but like specifically in psych, there are tons of different medications. And so it might seem overwhelming at first to like remember every single one of them. But the general like categories of medications or like the names that I keep in mind whenever I'm looking at second generation antipsychotics are things like anything that ends in penes, dones, or zoles. So in this case, aripiprazole is a second generation antipsychotic. Um, so you want to offer them oral first. And then if they're like not taking anything orally or if they're refusing it, then you want to go down the route of administering something intramuscular. Um, you might also have thought about haloperidol for the management of acute psychosis. And like, yes, you can administer haloperidol, but you usually go down that route if they're more severely psychotic. So like if they're agitated, like if this patient was combative with the physicians and like throwing chairs and like getting physically active, then you would want to go down the route of haloperidol. Um, and as a transition into what we're talking about coming up soon, you usually want to start with a second generation antipsychotic as opposed to a first generation antipsychotic. So haloperidol is a first generation antipsychotic. You usually want to start with a second generation antipsychotic for in general, but also for acute psychosis because first generation antipsychotics are more associated with extrapyramidal side effects, um, whereas second generation antipsychotics are not as associated with extrapyramidal side effects. So to introduce the conversation of side effects of first and second generation antipsychotics, we'll talk about like the four big pathways in psychosis, and obviously because it's involved in psychosis, it's also like pharmacotherapy. So there are four general pathways in the brain that are involved in psychosis. So we'll just go down this list. The mesolimbic pathway. Um, in this, if you have excess dopamine, that produces positive symptoms. So like the delusions, the hallucinations. Um, the way that I remember this is like the limbic pathway is kind of like, that's like the amygdala and like there are a lot of emotional centers there. So if you have a lot of dopamine, that activity is like super active. Um, and so if you have a really active limbic pathway, then you have like a lot of fear or like excitement or things like that. The amygdala is in overdrive, which can cause like delusions or hallucinations. I don't know. That's how I remember it. Um, you also have the mesocortical pathway, which you shouldn't confuse that with the mesolimbic pathway. Um, Decreased dopamine in the mesocortical pathway produces negative side effects. So the way that I remember this is like the cortex, you have like the sensory, and you also have the motor cortex. So if you don't have enough dopamine going to the mesocortical pathway, then, and I don't really know how accurate this is, but like if you don't have enough activity of the motor cortex, then you slow down and you're not moving as much. And so you have negative symptoms. Again, it's how I remember it. Um, this is also where you get into the realm of pharmacotherapy. So first generation antipsychotics primarily block dopamine. So they're really good at managing the positive symptoms in the mesolimbic pathway, but because you're blocking dopamine and negative symptoms are caused by decreased dopamine in the mesocortical pathway, if you're already blocking dopamine, then you'll worsen the negative side effects or the negative symptoms. So if someone who has schizophrenia primarily with like flat affect and avolition and like negative symptoms, you don't necessarily want to consider a first generation antipsychotic because it won't really help them. If anything, it'll make them worse. Um, and then these other two pathways aren't really involved in the symptoms of psychosis. It's more like side effects of the medications. So the tuberoinfundibular pathway, in this you have dopamine that inhibits prolactin from the pituitary gland. So if you are blocking dopamine with medications, you get hyperprolactinemia. And this is a high yield um, side effect that's associated with like one specific medication coming up. But like in hyperprolactinemia, you can like mess with, well, you can produce galactorrhea. That's probably like the most visible side effect. But you can also kind of get in the way of menstrual cycles and other um, endocrine abnormalities. So like if a man is taking a medication and then they have like gynecomastia or galactorrhea, or in a female as well, like if she's not breastfeeding and then all of a sudden she starts producing breast milk, then you want to think about hyperprolactinemia. And then the last pathway that's involved in this discussion is the nigrostriatal pathway. And this is where you get into the realm of extrapyramidal side effects when you block things like dopamine. And we'll see these extrapyramidal side effects coming up. Like we'll discuss them, but they're under the umbrella of the nigrostriatal pathway. Okay. Um, so before we talk about side effects, we'll reiterate first versus second generation antipsychotics. So first generation, these things end in zines. And then the biggest example is haloperidol. You won't see like zines as much. You'll see haloperidol a lot. And like I said before, these are associated with extrapyramidal symptoms, and we'll talk about those. And then, as I said before, second generation antipsychotics are like penes, dones, and zoles. So like aripiprazole, or like haloperidol, or sorry, not haloperidol, like paliperidone or risperidone is a second generation antipsychotic. And then like clozapine is a second generation because it ends in pene. Okay. Um, these second generation antipsychotics are associated with metabolic abnormalities. So a couple examples, olanzapine is a really high yield or classic second generation antipsychotic that's associated with like metabolic syndrome or like weight gain, stuff like that. And the way that I remember it is like metabolanzapine. Um, mirtazapine is also associated with metabolic stuff. And the way that I remember it is like mirtazapine, metabolic syndrome. Again, it's silly, but it's how I remember it. Okay, so hyperprolactinemia, like I said, is like the tuberoinfundibular pathway. You're blocking dopamine, and then therefore you get rid of the negative or the inhibition of prolactin, so then you get hyperprolactinemia. There's one particular medication that's associated with hyperprolactinemia, and it's risperidone. So if someone is started on risperidone, you want to think about hyperprolactinemia. And then you can usually switch to a different medication. I've seen aripiprazole as like the option that you switch to if someone is started on risperidone and they develop hyperprolactinemia. So keep that in mind. Here's a different medication is associated with agranulocytosis. This is clozapine. So this isn't my mnemonic, but I've seen like if you start someone on um, clozapine or clozapine, you want to monitor their white blood cell counts closely. So yeah, you can. There are a bunch of other side effects associated with clozapine, but agranulocytosis is like the highest distinguishing one that you don't really see in other medications. Um, there's also an antipsychotic that can prolong the QTC. And well, actually, now that I mention it, there are a ton of medications in psych that can like mess with the QTC, but um, there's one in particular. There's an antipsychotic in particular that can prolong the QTC. And that is ziprasidone. So I remember it as like zaps the QTC and makes it longer. That's how I remember it. Um, the whole reason why you're worried about QTC prolongation, you might be asked about this on a psych shelf, but it's also good to keep in mind for internal medicine or like maybe even surgery. Um, but you want to avoid medications that like significantly prolong the QTC, especially in someone that has like congenital long QT syndrome. Um, if they have, well, so you want to avoid QTC prolongation because that can put someone into torsade de pointe, which can be like a lethal or a fatal arrhythmia. So if someone has features of congenital long QT or they get an EKG and their QTC looks long, then you don't want to start them on ziprasidone. Or hypothetically, you might get a vignette where they have like a psych history and then they come into the emergency room and they get an EKG and it has torsade de pointe. And it's like, which of the following medications are they likely taking that's causing this? It would be ziprasidone. Okay, so as I promised, we would talk about extrapyramidal side effects, and here they are. So I'll talk about like the features, and we'll do a diagnosis and then a management of each one. So let's say someone comes into the emergency room and their neck is involuntarily turned to the side and they can't move it back, or like maybe their eyes are fixed in a certain position, or any muscle is like involuntarily contracted. This is acute dystonia. How do you manage it? You use things like diphenhydramine or like Benadryl, benztropine, and then you also want to change their antipsychotic. So, obviously you don't want this to continue because it can cause a lot of bad stuff and it can damage the muscle, cause like rhabdo. So, this you might see this in the case of someone who like recently started a different antipsychotic, and then like they went to their outpatient provider and then they had a new antipsychotic that they started and then that caused acute dystonia. You might also see this in the case like I've seen vignettes where someone like went to the emergency room a couple days ago because they had an acute psychotic episode and then they like got haloperidol and then a couple days later they come back to the emergency room because they have acute dystonia. Um, and it was like probably the haloperidol that they got to manage their acute psychosis that caused the acute dystonia. But in either case, diphenhydramine, benztropine, change antipsychotic if you can for acute dystonia. All right, what if someone comes into the outpatient office and you're doing an interview on them and they can't sit still and they're constantly like shifting in their chair. They have to like stand up and move around the office and they're like super restless. This is akathisia. And the way that I remember this is someone who has akathisia, they'll say like I can't sit still or I can't sit still. So that's how I remember akathisia. How do you manage akathisia? You give them propranolol, which is a beta blocker. And then obviously you want to change their antipsychotic. So you'll see this is a very common theme. But propranolol is like that'll help with their akathisia. Um, a way that you can remember propranolol for management of akathisia is it's also useful for things like performance anxiety, um, or like essential tremor, all of which like they're kind of jittery, they're like moving around, shifting, really uncomfortable. So propranolol is good for like all of these things. Um, but you get into complications and stuff when someone has like bradycardia. You don't want to do that. All right, let's say someone has been on a medication for a long period of time and they're like established care with a psychiatrist and they come in and you notice involuntary tongue darting. They're like writhing their head or their limbs or their trunk. This is tardive dyskinesia. This is like the most chronic um, side effect of extrapyramidal. Oh, this is the most chronic extrapyramidal side effect, like acute dystonia to akathisia, which is like subacute-ish, and then tardive dyskinesia is the most chronic. And it's usually irreversible. Like you want to avoid giving someone tardive dyskinesia. So that kind of spoils the answer to this question is for the management of tardive dyskinesia. As of right now, there's no curative treatment for tardive dyskinesia, but studies have shown that changing to clozapine reduces the risk of tardive dyskinesia, and it also can, to a certain extent, treat existing tardive dyskinesia. So if someone comes into like if you see a vignette and someone comes in with tardive dyskinesia and they're like, which of the following is the next best step in management? You'll probably like there's nothing to do because there's no cure or there's no like medication that'll cure it. But you see clozapine, you would probably want to click clozapine, just because that's like the best option available. All right. What if someone comes into the ED or maybe they're in the hospital already and they have like a sudden fever and you do a physical exam on them and they have like muscle rigidity. You get some serum tests and they have an elevated creatine kinase and hyperkalemia. This is neuroleptic malignant syndrome, um, which is basically like the fever and the muscle rigidity, yeah, like the medication that you gave them like causes them to tense up their muscles, kind of like acute dystonia, but like body wide. And because their muscles are constantly being used, they can like raise their temperature so they get febrile. And then they also start to break down. So you'll see things like hyperkalemia and elevated creatine kinase. So all of this because of the muscle stuff is neuroleptic malignant syndrome. Um, how do you manage neuroleptic malignant syndrome? If they're on an antipsychotic, you stop the antipsychotic like immediately. If you're asked to like give a specific medication, it's dantrolene. You give dantrolene. You also uh, give them fluids and you give them cooling to like reduce their fever and cool them down. So that's how you manage neuroleptic malignant syndrome. All right. Once you get a person stabilized with psychosis, you might be asked questions about like what are some good prognostic indicators for someone that has like schizophrenia. Um, if it's acute onset, so if they're totally fine and then all of a sudden they become super psychotic within 6 months, of course, right? Because that's the diagnostic criteria for schizophrenia. Um, the later in age that they are when they develop schizophrenia is a good prognostic indicator. If they're female, if they're predominantly positive symptoms, if they have no family history of schizophrenia or like psychosis. Okay, that's it. Um, so these are like some kind of things you want to have in the back of your mind for good prognosis for schizophrenia. And then if you just take the opposite of these features, that's what is a bad prognostic indicator. So if it's a chronic onset or like an insidious onset, if it's early in age, if they're male, if they have negative symptoms and their family history is like florid for schizophrenia, those are all bad prognostic indicators. Um, okay. You might also be asked, like, once you get an adequate antipsychotic pharmacotherapy, what else can you do to reduce the likelihood of recurrence of a psychotic episode? So let's say you get like the perfect antipsychotic regimen and you give it to the patient, but they still have these psychotic episodes. Like, what else can you do to make sure that they don't have these episodes anymore? Um, for some reason, well, I've seen family therapy is what you want to do in addition to pharmacotherapy. And it's perhaps because like if you have family therapy, then the patient is like better integrated into their family. They have better support, um, which also not only just gives them like more social integration, which can help manage their psychosis and their disability, but um, it might also be an element of them like once the family is better involved in their care, um, that or like more humanistically involved in their care, then it's like a better reminder to like take their medications and like do do things that we would normally take for granted in our lives, like going to school or getting a job or things like that. So they're not as isolated, and so then they don't go off the deep end for their symptoms. Okay. So we'll shift gears. This is the last topic that I'm going to talk about in this episode. And every single time I make an episode, it's surprising how long it goes. So we'll talk about mood disorders and then we'll be done. Um, all right. So this is pretty high yield as well, like making a differentiating between major depressive episode and things like adjustment disorder. You'll see tons of questions where it's like, which of the following is most likely diagnosis? And it's like MDD or adjustment disorder. Major depressive disorder is at least 2 weeks of at least five of the following symptoms. This is where you get into the SIG caps mnemonic. So depressive episode, at least 2 weeks of at least five. You can see them here, but sleep loss, interest loss, like anhedonia, is how it's described, is the term that describes it. Guilt, if they have energy loss, if they have concentration loss, if they have a change in their appetite or weight, um, if they have psychomotor slowing, and then if they have suicidality. Those are all of the possible features of a depressive episode. Um, how do you manage someone with major depressive disorder? It's CBT and an SSRI. Those are like, and then you can just kind of pick whatever is with an SSRI. Um, what specific medication do you want to choose if the patient has like no appetite and they've lost a ton of weight? So you might see the vignette and then it'll be like a bunch of different SSRIs in the multiple choice answers, and you're like, well, which do I pick? If they have no appetite and they have lost a ton of weight, You want to give them mirtazapine. As we were seeing earlier, mirtazapine is like actually one of the antipsychotics, but it's associated with like increased appetite, increased weight, or like I was remembering with a mnemonic, like metabolic syndrome. So if you give them mirtazapine to help with with their depression, um, and they have no appetite and they've lost a ton of weight, it'll help with not only the depression, but it'll help with them with the appetite and like gain some of that weight back. Um, what are, okay, so we just talked about major depressive disorder, and so we'll contrast that with adjustment disorder. So the features of adjustment disorder are if they have mood or behavior change in response to an identifiable stressor. So there has to be something that precipitates a mood or behavior change. So it could also be like adjustment disorder doesn't have to be just depression. It could be like adjustment disorder with depression. It could be adjustment disorder with anxiety. It could be adjustment disorder with like specifically just change in behavior. So it's like if a kid, or maybe not a kid, like an early 20s or something, um, or like a teen. I don't think there's an age cutoff for adjustment disorder. Um, if there's like this identifiable stressor, um, like let's say they like a patient like recently had a breakup and then like they're acting out and they're losing their mind, um, but like their mood is okay, they're just acting out. You would want to think adjustment disorder. Anyway, so mood behavior change in response to an identifiable stressor. The stressor has to be within 3 months of the change in the mood or behavior. And then the mood and behavior change reverses within 6 months of removal of the stressor. So those are the time frames to keep in mind for adjustment disorder. You'll also be masked. You'll also be asked on the management of adjustment disorder, and that's just supportive psychotherapy, as opposed to CBT as SSRI for major depressive disorder. Um, I should also say for adjustment, so you can also have like a depressive episode exacerbated or like precipitated by an identifiable stressor, and that's where you can kind of get confused between depression and adjustment disorder. So another way that I've seen adjustment disorder like differentiated from major depressive disorder is um, adjustment disorder is like the mood or behavior change is like significantly out of proportion to the identifiable stressor. So one of the examples that I heard was like someone recently lost their dog, like their dog passed away, which is very sad. Like it's not, oh, they lost their dog, it's fine. Like it's a sad thing, but if it's like they lost their dog and then for like 3 months they're like locked inside, they're not doing anything, but they're not meeting the criteria of major depressive episode, then you would want to think more adjustment disorder. But again, you can still have like another thing, like if there's an identifiable stressor described in the vignette, you still like you don't want to immediately think, oh, there's an identifiable stressor, it's adjustment disorder, because you can still have a depressive episode. So what really in that case, what you can do to make the to like decide between depressive episode versus adjustment disorder, as you're reading through the vignette, what I like to do is I'll like highlight the specific symptoms they have that are significant or that are consistent with SIGI caps. So if the patient is describing like, oh, I can't sleep, that's sleep loss, I highlight it. So it's like, all right, that's one. Um, and then they're like, oh, I don't like going out and playing cards with my friends anymore. That's interest loss. I highlight that. That's two. And then I keep doing that until I get at least five. And if it's five, I'm like, all right, that's depression. I'm moving on. But if they have like three or four, that doesn't meet the criteria for depression. And so then it's adjustment disorder. And then because this is all important because it changes their management. Okay. You might also see someone comes in and they have like lead-like heaviness. They can't really move their arms all that much. And they're like, I just feel super heavy. They have weight or appetite gain. They're sleeping all the time. Um, and then, you ask them to describe something good that happened recently, and they have like a brief improvement in mood after something good happens. And then they also have like hypersensitivity to interpersonal rejection. So what are you thinking like diagnosis wise for this? Okay, this is atypical depression. Um, for some reason, like these are just features that are classical for atypical depression, specifically like the sleep excess versus the sleep loss in depression, and then like the improvement in mood after positive events in the sense that like these are all just very kind of one-off features that are significant or that are consistent with atypical depression. And then of course, how do you manage atypical depression? It's CBT and SSRI, just like it was for typical depression. Okay, I think that's all I wanted to say for this. Uh, yeah. Okay. You will also have to assess a person's suicide risk, um, if they have any like mood disorder or just in general on psych and step questions. So this is where the sad person's mnemonic comes into handy. If they're so one by one, sex, if they're male, they have an elevated risk. If there's a bimodal distribution for age, for a risk of suicide, and that's like if they're younger than 19 or older than 45, they have an elevated risk. If they have depression, if they've had a prior attempt, if they have excess substance use, so like drugs or alcohol, if they have rational thought loss, if they're separated or single, if they have an organized plan, if they have no social support, or if they're sick, like with a physical illness. I mean, mental illness is also sick. This is like if they have like an infection or if they have cancer or something like that. Um, these are all risk factors. And then you'll also be asked, like, which of the following is the most significant risk factor for suicide is if they've had a prior attempt. Okay. That kind of transitions us into indications for inpatient psychiatric admission. So it's like you might also be like, which of the following is the next best step in management? And it's like send them home or admit them to the hospital. Um, if someone is a risk of harm to their self or there's a risk of harm to other people, that's an indication for inpatient psychiatric admission. So if they have like these risk factors, like a sad person's risk factors, or they look like they're going to hurt someone else, that's an indication for inpatient psychiatric admission. This is not just unique to psych questions, but it's like one of those ethical questions. Um, what are like situations in which parental consent is not required to treat a patient? Like if they're a teenager younger than 18 years old, um, it'll be like, do you need to get consent from their parents? And then it's like, no, and why, or something like that. Um, if there are any concerns for psych, substance use, safety, or sex, those are all situations in which you don't explicitly need parental consent to treat the patient. So the way that I remember it, it's like the four S's. So there's like a lot of alliteration here. Another one-off question that you might see is like, what are indications for electroconvulsive therapy in someone that has a mood disorder? Um, if they have psychosis, so if it's like MDD with psychotic features or schizoaffective disorder, if they have catatonia or like the waxy flexibility, or they're just not moving at all. If they're suicidal, that's an indication for electroconvulsive therapy. If they have malnutrition, so if they're like refusing to eat or like take care of basic needs, that's an indication for electroconvulsive therapy. Um, Another important thing to remember it kind of might seem contrary to what you think, but it's okay to use in elderly patients and in pregnant patients. Um, because like the medications that you can give to manage mood disorders and psychosis, they can have a bunch of side effects, which can really do some harm to elderly patients and in pregnant patients because of their teratogenicity. So in those patients, you can actually go down the route of electroconvulsive therapy. Okay, I think we're almost done. I think this might be my last slide. So we were just talking about major depression versus adjustment disorder. So then we'll talk about bipolar spectrum. So it's like bipolar 1, bipolar 2, and cyclothymia. Um, Bipolar 1 is like number one. This is where you have manic, like this is like slam dunk bipolar. This is where you have a manic episode. You actually don't need depression or like a depressive episode to make a diagnosis of bipolar 1. If they have a manic episode, it's bipolar 1. And there's also specific features of uh, of a manic episode. So it's at least 7 days of the following features, or if the patient requires hospitalization. So if they're a risk of harm to themselves or if they're a risk of harm to their others and they're admitted to the hospital and you're like looking through their chart and they have a history of admission for a manic episode, or they need admission in this current episode, that's bipolar one. It's manic episode. Um, so the mnemonic to remember features of a manic episode are dig fast. So distractibility, impulsivity, grandiosity, flight of thought. So their thoughts are like all over the place. Activity increase. So if they're like, and this kind of ties in with sleeplessness as well. But if they're like, you might see a college student who is up all night, every night for like 2 weeks, or maybe 1 week, because then that would be closer to the 7 days. But anyway, if they're like up every night studying for an exam and they're like scribbling their notes all over the place and they think that they've like unlocked the secret to the universe, you would want to go down the route of a manic episode. And then if they're talkative, so if you're doing an interview on them and they're just like not giving you any space to answer their questions or to like put a single word in because they're just talking all over the place, then that's significant talkativity. Um, So we'll contrast that with hypomania, which is consistent with bipolar 2. So this is like you have some features of mania, but it's not to the point where it's causing like dysfunction or disability um, to the extent of a manic episode. So they're like elevated, but not to the point where it's a full-blown manic episode. And you'll also see fluctuations with depression, like depressive episodes similar to major depressive disorder. So contrast that with bipolar 1, where you actually don't need a depressive episode to make the diagnosis of bipolar 1. Um, so that's one thing that can kind of tip you towards making the diagnosis of bipolar 2. And then if they have like a couple mild features of mania, but not to the point where you're like, this is a manic episode, you would want to think bipolar 2. Um, And then the last thing that we'll talk about, or the last condition in this spectrum is cyclothymia. This is like closest to normal that you can get, where you'll have like elevated mood that is like above normal, but not to the point where you have hypomania. And then you also have depressed mood that is not yet reaching the level of like major depressive disorder. Um, while I'm seeing this, you might like so you might get confused, not with cyclothymia, but like bipolar 2, if they have depression similar to MDD, you might be like, well, then how do I make the difference between bipolar 2 and major depressive disorder? Major depressive disorder, they only have these depressive episodes. They don't have any hypomania. It's like either they're normal and then they have these 2 week periods of just not doing anything and like depressant or depressive episode. Bipolar 2, they have these depressive episodes, but they also have hypomania. So you don't see hypomania in MDD. Um, and then if we're talking about cyclothymia, where they have the elevated mood not yet reaching hypomania, and then they have the depressed mood not reaching MDD, you might also think, well, cyclothymia versus um, dysthymia, or I think more recently is called persistent depressive disorder. Um, in persistent depressive disorder, you only have the depressed mood not yet reaching the level of a major depressive episode, and that's like for 2 years, if I'm remembering off the top of my head. So there's like no hypomania, and it's just like persistently depressed mood for like at least I want to say it's at least 2 years. Is consistent with dysthymia or persistent depressive disorder. Okay, and then of course, how do you manage bipolar? Um, Medicines include lithium, valproic acid, quetiapine, and lamotrigine. There are a bunch of other different medications, but like these are the highest yield ones. Lithium is particularly important to remember because it is the one medication that like reduces the suicide risk um, in bipolar disorder. And then for someone who has a history of bipolar or like manic episodes, contraindicated medications to give are things like SSRIs or other antidepressants because those could precipitate a manic episode. So, like, let's say someone comes into the outpatient office and they describe what is very consistent with um, like a major depressive episode, and like that's their chief complaint for this episode. One of the things that you want to elicit in their history is if they've had a history of a manic episode, or like you would look in their chart to see if they had a history of a manic episode. Because if they do have this history, you would want or you would not want to start them on an SSRI because there's a risk of precipitating another manic episode. Okay, that's it for this episode. I was anticipating this one to be significantly shorter. I almost hesitated putting this one out because I wasn't sure if there was going to be enough content to cover, but I think I covered more than I thought I would. Um, but all that is to say, as always, thank you so much for your attention and for sticking with me to the end if you're hearing my voice at this point. Um, I am going to go. And with that, I wish you all the best. If you're on your rotations, good luck on your rotations. I hope you're having fun and seeing a bunch of really cool stuff. Don't get too bogged down in studying. Um, I hope this was helpful. I have fun making these, but I really hope this is as helpful to you guys as possible. As always, give me feedback on things that I can do better, specific content areas that you want me to go over. I'm very open to hearing those suggestions. If you're currently in the trenches of dedicated for step two, I wish you the best of luck. You'll do great. Um, all right, I'm going to stop talking. Thank you.